Good morning. Thank you all for joining us today for our fourth panel discussion on the novel COVID virus and the CU Anschutz Medical Campus. First, let me express our gratitude. We have made significant progress in facing this pandemic over the course of the last year, and we couldn't have done it without the people that I'm not only surrounded by on the screen, but the people in the audience today. Philanthropic support allows us to be nimble in our response to COVID-19 as the needs of our community change and evolve. With your support, we are developing new treatments to those we serve, all the while our campus and our hospital partners are playing an integral role in vaccinating Coloradans as swiftly as we can and as supply dictates. I also want to thank our entire campus community, researchers, physicians, and students who are constantly adapting in the face of these changes to deliver on our research, clinical, and education missions. As we look to the future, we hope to carry forward the momentum of promising vaccine efforts underway. This shift brings both hope and unique challenges as we continue to come together to pursue a brighter tomorrow. Our moderator and our panelists will bring key perspectives to our conversation about where we stand and where we're going, specifically addressing vaccine development and vaccine distribution for our community and what this means for all of us going forward. Today, we are joined by the School of Medicine Dean, John Riley, who will moderate the panel today. If you've tuned in on any of the previous panels on this topic, you'll recognize many of the panelists we have with us today. First is Dr. Michelle Barron, Professor of Medicine in the Division of Infectious Diseases at the CU School of Medicine and the Senior Director of Infection Prevention and Control at UC Health. She will address new variants of the virus as well as what it means to be vaccinated. Next, we have Dr. Richard Zane. Rich is Professor and Chair of Emergency Medicine at CU School of Medicine, and he's also the Chief Innovation Officer at UC Health, overseeing innovation for the hospital system, as well as the emergency departments, urgent care centers, and virtual health. He will share how we are structuring vaccine distribution to reach as many of our community members as possible, as quickly as we can. Then we have Dr. Thomas Campbell, Professor of Medicine in the Division of Infectious Diseases at CU School of Medicine, with a specialty in clinical trials of viral infections, including HIV/AIDS and COVID-19. He is the Associate Dean for Clinical Research, and he will share insights on variant strains of the virus and what the implications are for ongoing development of additional vaccines. Last and certainly not least, we have Dr. Rosemary Rochford, Professor of Immunology and Microbiology and co-director of our Climate and Health Program, who will share her perspective on how the virus is adapting and changing and what we can expect as it continues to do so. While we have some questions for our panelists, we would also like to hear from you. Please share your questions in the chat window and Dean Riley will address them as time allows. With nearly 2,000 benefactors or over 2,000 benefactors attending today, we probably will not be able to address all your questions, but we'll do our best to provide a thorough overview of what we know now. We encourage you to visit the CU Anschutz newsroom for the latest updates on this topic. John, over to you, and thank you for moderating the conversation today.
Thank you, and good morning, everyone. I want to extend my thanks as well as Don's for your attendance here today and your ongoing support of the campus. We've got a lot of ground to cover today, so I'm going to open it up with a series of questions and then do my best to address recurrent themes that come up in the chat in the time we have left after our scripted questions. So I'm going to start with Dr. Rochford. Obviously, big news across the United States is this vaccine rollout and concerns about some people have about accepting a vaccine. One of the issues is if the duration of antibody protection, and is there a preference for one vaccine over another?
Yeah, great questions. First of all, I just sort of think about if we think about the stability of immunity to SARS-CoV-2, so if you get the natural infection, what happens? And there's a lot of variability in that data in terms of how people's immunity is lasting if you have severe disease, asymptomatic disease, And so it's only a year in. And so what we know about our immunity to SARS-CoV-2, a lot of it is based on stability to SARS-CoV, where we see the antibodies declining after about 3 years, and then T cell responses are longer. In terms of thinking about vaccines that we have now, we have the J&J, the Moderna, and the Pfizer that now all have emergency use authorization. All of them are designed to focus our immune response against the spike protein of the SARS-CoV-2 virus. And it's important to think about if we have a vaccine versus a natural infection. When you get the infection, your body's trying to figure out how to fight off this virus. You get systemic inflammation, all kinds of problems. The virus is also trying to keep you from mounting a good immune response. And so because of that, we make a lot of different types of antibodies to the virus, a lot of different T cell targets. But when you get that vaccine, you get just a focused immune response against that one thing. So your body only has one thing to do, and it's to make an immunity to the spike protein, which is the protective part of the immune response against the virus and its invasion. So all the vaccines that are out there right now, the Moderna, Pfizer, and the J&J, are all targeting that spike protein of the virus and just giving our immune system one thing that they have to do.
Thank you. Dr. Campbell, you were involved in a lot of the, a number of the vaccine trials. Can you, for the audience here, sort of briefly summarize the efficacy and what the most common side effects are and how severe they are after vaccination?
Yes, I'm glad to. So as Rosemary said, we now have 3 vaccines that have been given emergency use authorization by the FDA, Pfizer, Moderna, and Johnson & Johnson. The Pfizer and Moderna vaccines, which are 2-dose vaccines, they have an estimated efficacy in the 94 to 95% range across the board. The Johnson & Johnson vaccine is a 1-dose vaccine, and the efficacy for preventing symptoms or symptomatic SARS-CoV-2 infection is a little bit lower, around 70 to 74%. But it still remains highly effective, greater than 85% effective for preventing severe infection, so meaning infection that's severe enough to put you in the hospital. The safety of all 3 of these vaccines is excellent. The main thing that we see is injection site and injection reactions. So what I mean by that are the reactions that occur fairly shortly after getting 1 or both injections in the case of a 2-dose vaccine. And usually this is within 24 to 48 hours, sometimes out to as long as 7 days, but certainly all within the first week. And this can be things like pain, swelling, and redness at the injection site, or systemic symptoms, flu-like symptoms, so fever, headache, chills, muscle aches. And these symptoms are pretty common. So in the Pfizer and Moderna vaccines, up to 70% or so of people will get something. And the risk is greater after the second injection than the first. The J&J vaccine, which is only a single dose, has a lower risk of these side effects, probably in the 35% range, probably because it's just a single dose vaccine. In terms of more serious side effects, the clinical trials did not detect any other serious side effects that were higher in the vaccine group versus the placebo group. Since these vaccines have been rolled out and have now been given to tens, if not hundreds of millions of people, we are seeing some things pop up like allergic reactions, for instance, but these appear to be very rare. So in general, what I would say is all 3 vaccines have excellent safety records.
Thanks very much. And I want to note for our audience that I did my unscientific poll of the panelists prior to us coming on the air here. And Dr. Rochford participated in one of the clinical trials for vaccines, and the others of us have been vaccinated. So we believe the data, and we hope to convince you to believe the data as well. So Rich, Zane, Dr. Zane, hot topic now is who can get the vaccine when, how does the distribution work? Who sets the priorities and what's the rationale for the priority systems that are out there?
Thanks and good morning. I think what's really important to describe is, as the other panelists have intimated, the development of a vaccine in this short period of time is nothing short of miraculous, especially vaccines that are so effective and safe. From the perspective of the chain of command, who owns the vaccine, who makes decisions, all of the vaccine is purchased by the federal government and then allocated to states based on population. The CDC sets guidelines for how and who should be vaccinated, but the states decide. So essentially, the state of Colorado decides who can be vaccinated and where they can be vaccinated and how can they be vaccinated. The state of Colorado has partnered with a number of different entities, initially almost exclusively healthcare systems, but now also pharmacies and others to be able to vaccinate. Everybody has read about the different vaccines and the logistics about the vaccines, specifically the Moderna and the Pfizer, which have been out for a couple months, and then now the J&J vaccine, and the phasing of who gets to get vaccinated first. In the context of the logistics of vaccination and the phasing, I think it's really important to note that there's vaccine scarcity, which means there's not enough vaccine for everybody that wants it, which is why there had to be a prioritization. And the CDC essentially prioritized based on two factors: who is needed to be vaccinated so they don't become ill and can have continuity of services, whether it's healthcare, government, essential services. And then the other end is who is most at risk of dying from COVID. From the perspective of most at risk of dying from COVID, although we have read, and you have read a lot about comorbidities and those who are most at risk, the single and most important confounding variable that contributes to severe illness and death is age, which is why the CDC started with a recommendation over 75. Colorado had over 70 as the initial phase. And then also healthcare workers and those on the front lines of healthcare. And then there are a series of phases, and we are now in a phase where those over the age of 65 and teachers, in addition to frontline workers, are able to be vaccinated. And soon, in the next week or so, they will also add those over 60 or those with 2 or more comorbid medical conditions. The logistics of that are really complicated, and think about Pfizer and Moderna need to be subarctic frozen and delivered in 2 doses. The J&J, which is why everybody is so excited, can be refrigerated at normal human temperatures and given in 1 single dose instead of 2 doses. So there's phasing and logistics and vaccine scarcity, which contribute to the very complicated logistics, and probably one of the most logistically complicated things the United States has ever done.
Thanks. Another question for Dr. Campbell here that's come up several times in the chat, and that is the effect of vaccination on carrying the virus and potentially transmitting it to others, even though you've been vaccinated.
Yeah, very good question. So the vaccines, all 3 vaccines, were designed to prevent illness. And that was their primary intent. And that was the way the clinical trials were conducted, was to assess protection against illness. And we know that all 3 are very effective in doing that. However, we also would like vaccines to protect against infection and protect against transmission to others. And we have much sparser data on the ability of the vaccines to do those things. We do have some data, and perhaps the best data that I've seen so far comes from the Johnson & Johnson trial that was just reviewed by the FDA last week. And in that trial, they did measure asymptomatic infection, and the Johnson & Johnson vaccine was still highly effective against asymptomatic infection, around 74% effective. We have less data with the other vaccines. Moderna has some estimates around 57%, AstraZeneca a little bit lower, around 25%. Of course, AstraZeneca is not yet approved in the US. So we have data emerging, and there will be more data coming out in the next several months, and we'll be able better to answer that question in a short period of time.
Thanks. Another question for Dr. Rochford here. We hear a lot of terms being thrown around about vaccines, adenovirus, mRNA, et cetera. Can you talk about the different vaccine platforms briefly for a lay audience here, as well as what kind of background research had to be done over the last couple of decades in order to be able to move these vaccines so quickly over the last year?
Yeah, great question. So one of the things to think about is that although SARS-CoV-2 is a new virus, we've actually been studying the coronaviruses. In particular, we had the SARS pandemic and the MERS pandemic or epidemic prior to this. And so studies of SARS-CoV showed that the spike protein was the immunodominant protein, that the key target for immunity to protect you against it. So information was built on that. And in addition, these different platforms have been used for different vaccines. For example, the one for the Johnson & Johnson, the adenovirus vector one, was based on studies for Ebola virus. And then they just swapped out that spike protein. So if we think about a number of different platforms, the traditional way to make a vaccine, actually the original vaccine, the smallpox, was the making not an inactivated, the cowpox, a similar virus and causing immunity. In the 50s and 60s, we did a lot of work with inactivated viruses or with attenuated viruses. But in the last 2 decades, we've really think about it differently. So the adenovirus, a vector virus, is basically you take the part of the spike protein from SARS-CoV-2 and put it into another virus, but it's not going to be alive, and you use that to deliver it into the cells. So a vector of another virus, so you pop it right in. So a lot of research has gone into those adenovirus vectors. In the Johnson & Johnson, it's a human adenovirus, and adenoviruses can cause sort of the common cold, so there are a lot of different variants of them. The AstraZeneca is a chimpanzee adenovirus. And again, these viruses aren't infectious, but they're enough to generate immunity to that spike protein. The Pfizer Moderna use messenger RNA, and it's important to realize messenger RNA, when you think about the information highway of our cells, DNA makes mRNA makes protein. So we're going to go not from the DNA part, but we got that middle part. So messenger RNA, it's surrounded in a lipid bubble, gets inside the cell and immediately starts turning your cell into a little virus factory to then make that spike protein. And in particular, it makes just the receptor binding domain of the spike protein. That messenger RNA is very unstable, so it's going to get degraded after it does its job of helping the cell make the protein to get the immune system going. So it's not going to stick around. It doesn't get inside the nucleus where the DNA is. It's only in the cytoplasm. And so those are the two. So the adenovirus vector, so you take a non-replicating virus, put the spike protein in. So that's the Johnson & Johnson that's authorized. And then the mRNA, you put in the just around a lipid bubble, and it's just that one part of the virus to get that immunity going. And I think, it's really a tribute to a lot of generation, and as Dr. Zane said, to get from discovering and sequencing the virus a year ago, January, to having this vaccine, all these different platforms. And I'll note there's at least 46 platforms around the world in clinical trials, right? So the 3 we have right now are the sort of the first off the gate, but there's many more also out there looking at all these different factors in that. And the last point I just want to emphasize is they're all the ones that are out right now are really targeting that spike protein. And that's, when you think about the coronavirus, the spike is the ones that are sitting outside, and that helps neutralize, the antibodies will neutralize that virus getting inside the cell.
Okay, thanks. So I think, as Dr. Rochford said, it's important for people to realize that these vaccines are introducing a protein derived from the virus, but not the whole COVID virus. So it does not infect people with COVID-19. So Dr. Barron, one of the issues, other than tiering of vaccines and timing of availability, is the emergence of these variant strains. So can you talk a little bit about variant strains, how they happen, what the implications are now, and what the implications they are for vaccines now and in the future.
Sure. So when we talk about variants, basically the way viruses replicate themselves is they copy themselves. All viruses will do this, but it's and some of them are more sophisticated when they do it than others. There's proofreading mechanisms that they have so that when they copy themselves that they do it correctly. But obviously they can make errors. And when some of these errors occur, it can change what the virus looks like. And some of these changes can be very subtle. And I sort of use an analogy of like changing my hair color. You would still know it was me, but I have a different hair color. And then some are more dramatic where it doesn't look like me at all and where you wouldn't be able to recognize me. And that's important in terms of your immune system being able to like recognize and then be able to respond to this. And so it's not unexpected. Viruses do this. Some of these do this more rapidly. Some of it do it more slowly. So that's not actually something that's a surprise that these will occur. Again, the question is, well, how dramatic is that shift, and will it allow our immune system to still be able to recognize and respond? Of the variants that have been circulating, obviously there's been a lot of questions about the vaccines and whether the vaccines are still effective. I think we don't fully know that answer, although in studies that they've been doing in the lab, it does appear that the current vaccines are still effective. I think we will continue to have to monitor this closely because we, again, don't know where they're going to change. The other piece that's come up in the news, and just to be aware, there is one other way that viruses can actually have these variants can develop. And so in addition to the copying errors, they can also intermix with other strains and pick up pieces of the other virus. And that, again, can make that look a little different. We see this with flu every year. With flu, we have to get a new flu vaccine because it potentially has some of these things going on. And so, again, it's something we're not obviously we are watching this very closely, but we don't have any information so far that the vaccines aren't effective.
Thank you. The big question on a lot of people's minds for Dr. Campbell is, will we need to develop new vaccines as these variants emerge, and or will we have to get a yearly shot like the flu shot?
So the simple answers are yes, we will have to develop new vaccines. And the second question of whether we'll have to get boosters every year, we don't know yet. So what we do know is that from the data that we have, which is somewhat sparse, is that the emerging variants are the vaccines protect less against the emerging variants. They still protect, but they protect less. So for instance, the variant that was first detected in the United Kingdom, the B.1.1.7 variant, the Novavax vaccine is only 86% effective against that variant versus the ancestral variant that was there before that, where it's about 95% effective. The variant that was first detected in South Africa, the B.1.351 variant, the Novavax vaccine is about 60% effective against that variant. Johnson & Johnson is probably about mid-60s, about 65% effective, and AstraZeneca somewhat lower, around 25%. So these variants, even though we call them the UK strain or the South African strain, they're emerging simultaneously in different parts of the world. It just so happens that these were first detected in the UK and South Africa, but we're actually seeing similar mutations arise spontaneously in other parts of the world. This is because as the virus spread, it's adapting to infecting humans versus the bats, which were its natural host before it came to us.
Thanks. So the next question up is for Dr. Rochford. Now that vaccines are available and rolling out, this question of herd immunity has arisen. So what is herd immunity, and what level of immunity do we have to reach in the population in general to have meaningful herd immunity?
Yeah, great question. So an important thing to think about, especially like this virus is new to the US population. So when it emerged, everybody's susceptible. And a virus to sort of keep going needs new susceptible hosts, that's us, to spread in the population. So herd immunity happens when a virus can't spread because it keeps on encountering people who are already protected against that infection. So it sort of basically can't get to a new susceptible host. So wide-scale vaccination programs like we're seeing now for SARS-CoV-2 are designed to generate herd immunity in the population. And when a sufficient number of the population is immune to the virus, this also reduces, and it's an important point, the risk to vulnerable people who will come into contact with the virus. And that means high levels of vaccination-induced immunity in the population benefits those who can't receive or sufficiently respond to a vaccine, like people that are immunocompromised. So herd immunity actually helps prevent vulnerable populations as well, people that can't generate good immunity. So the question is, what percentage of the population? And this is sort of an epidemiologic modeling question. And we have to think about two things that come into play. The first is how infectious is the virus, and second, how efficacious is the vaccine. So if we think about measles virus, use that as an example, the vaccine is highly efficacious, but the virus is one of the most infectious viruses known. So we need to have about 95% of the population vaccinated to generate herd immunity to measles viruses. With SARS-CoV-2, it's clearly not as infectious as measles virus. It's actually quite a bit less infectious. But as Dr. Campbell just mentioned, we're trying to understand sort of the efficacy of that vaccine for blocking transmission. And that data, we're just getting in on how those vaccines are going to help block transmission. So as we understand that, we'll get a better sense of the numbers. But right now, the estimates, and I'll just say this estimates, is we need about 70% of the population vaccinated to generate herd immunity. And importantly, it's also, I just want to mention, we want to get herd immunity. It's always designed through vaccination, not natural infection, because we think about the mortality and morbidity rate with just a natural infection. You don't want 70% of the population naturally infected with this virus and creating a severe problem. So we really focus on herd immunity through vaccination. And as I said, right now, an estimate is about 70%, but it depends on how those numbers, and we understand with the vaccines blocking transmission, how that data is going to come out to get a real hard number. But I would just say everybody get vaccinated as quick as we can so we don't have that virus have a chance to replicate, make more variants, and protect our vulnerable populations.
Thanks. This is for Dr. Zane. A question that keeps appearing in the chat, and one we had anticipated. There are various themes on this question, but basically, how can somebody get vaccinated, and what's a realistic timeline to think when the vaccine is not going to be supply limited?
So to answer the last question first, I have every confidence that if we even believe half of the vaccine supply that the federal government is promising states, that everyone who wants a vaccine, and I hope that everybody wants a vaccine, will have the opportunity to be vaccinated by the end of summer, and probably even earlier. The way that the tiering works, this week or next week, we will start with 60 and over, and also include those under 60 with 2 or more comorbid medical conditions. Currently, there isn't one centralized way in which one can register to be vaccinated or sign up to be vaccinated. And it requires often going to different registrations, whether it's CVS or Walgreens or different healthcare systems. If you are a UC Health patient, you are automatically registered and you are automatically randomized to receive an invitation to schedule a vaccine. If you are not a UC Health patient and wish to be registered, you would go to the website and register, and you self-attest whether it's your birthday or comorbidities.
Thanks. So Dr. Barron, this question's for you. I got vaccinated. Do I still have to wear a mask? What is life like after vaccination for the year 2021 anyway?
So the short answer is yes, you still need to wear a mask. So there's a couple of factors in this, and this is not, you have to wear a mask when you go to bed, obviously, but there's obviously times when it's still important. So the first thing to know is that the vaccine does take time to have its full effectiveness. So just because you got your shot doesn't mean that suddenly your immune response is there and you can go and do whatever you please. There's improvement from the first to the second, but people have gotten COVID and gotten sick in that interval, and they've gotten sick even after the second dose. And so it usually takes on average about 2 weeks for you to have full immune protection from your vaccine. Again, similar to a lot of other vaccines that we receive. And so wearing a mask is going to still be obviously one of the ways that we prevent that. The other part of this is that not everybody is vaccinated. And so kind of going back to the question that's been asked about, so there's two pieces to this. So not everybody's been vaccinated. So there's certainly potential for you to get exposed and hopefully protect it, potentially infect it. But also the question about, well, can you still become infected and maybe be asymptomatic and then potentially shed it? And so wearing a mask, again, prevents that. The last reason to wear this is we don't know the role of the variants yet. We know that there's probably some effectiveness, but maybe not as much as this with the regular ancestral strain. And again, prevention against the variants which are on average 30% more contagious. Again, wearing that mask prevents you from actually having that transmission or spread. And so there will come a day, hopefully, where we don't have to wear them as frequent, but I anticipate this is going to just be part of our lives for a long time moving forward. And I realize it's not comfortable. Sometimes it's just inconvenient, but the protective effect of that is actually huge. And not only by you protecting yourself, but also protecting others.
Thanks. This one is for Dr. Campbell. We have a fairly robust, at least short-term data of vaccination efficacy in adults. What's the status of vaccination for children? And since getting to that 70% would involve children, what do you see the timeline for clinical trials in kids being?
Yeah, that's a very important question. About a quarter of our population is children, and to get to herd immunity, we need to vaccinate children. SARS-CoV-2 is spread less efficiently by children than adults, but it's still spread by children, so we do need to vaccinate them. We don't yet have data about how well the vaccine works or their safety in children under the age of 12. Those studies are currently enrolling, and we should have information probably in 2 or 3 months. So hopefully by the start of the school year in the fall, we'll have vaccinations available for children.
Thanks. So a couple things emerging in the chat. One is with the emergence of these variants, and I think I will direct this one to Dr. Rochford. With the emergence of these variants, do we run the risk of another wave of clinical infections similar to what we had last spring or this fall?
Unfortunately, yes. So again, I want to just emphasize why it's important for us to get vaccinated so these variants can't keep, as Dr. Barron said, the virus, it's designed to make mutations and try to escape our immunity. So we have to be, I think this really emphasizes why we need to keep our strict social distancing, our face mask wearing. Even if we have been vaccinated, I actually double mask when I go out, even though I'm in a clinical trial, sort of assuming, I'm just sort of making that assumption that we want to make sure that we're not going to get exposed to any of these variants. So I really think it's important for all of us to do all we can so that we don't give those variants a chance to take hold, whether they emerge within different parts of the world. And I'd also like to sort of make it another point about the variants. It really emphasizes why we need to think about vaccination worldwide, because we don't want to have the entire US population vaccinated and not have these variants being able to emerge in other places where there's still epidemic disease occurring. And I think that's important. And that's strength of the J&J vaccine, as well as that cold chain, that it only needs 4 degrees in a single shot, is a really, I think in some ways, a game changer in terms of expanding vaccination to a greater portion of the population.
Thank you. A quick question for Dr. Campbell here. When do you anticipate these vaccines going from emergency use authorization to full approval by the FDA?
Yeah, that's a good question. And it's important to make that distinction because all 3 vaccines right now are authorized for emergency use, but none are approved. And that will take some time, but probably sometime later this year.
Okay, thanks. This is a question for Dr. Barron. There have been questions in the chat about the risk of pregnant mothers passing COVID to unborn or newborn children. Do we have, how much information do we have about that?
Yeah, so there's certainly, when you look at who gets COVID and who gets complications from COVID, women that are pregnant seem to have higher complication rates. I don't know if Dr. Rochford or Campbell can comment. I don't recall if there's been any data specific that shows COVID is transmitted in vivo through the placenta to the baby. But certainly if mom's having complications and mom is sick, obviously that can impact the baby. And so that is where some of the obese societies have come out and said, you know, we understand there isn't a lot of data in pregnancy, but pregnancy in itself is a high risk, and you weigh those risk benefits in terms of deciding how high risk are you, what trimester are you in, how comfortable you are. But they are recommending that women strongly consider, women that are pregnant, strongly, or even breastfeeding, strongly consider getting the vaccine to have that protection so that they don't have complications related to the illness otherwise.
Thanks. This next one is for Dr. Zane. A number of questions in the chat around specific groups of people and whether the vaccine is safe. So people with autoimmune disease, people who are immunocompromised, should they be getting the vaccine? And then what's the strategy for people who have had COVID? Should they get vaccinated, and if so, when?
So the vaccine is safe and recommended for everyone. There are no contraindications currently to being vaccinated other than the age contraindications. For the medical conditions that you listed, they would be specifically indicated for vaccination because they're relatively immunocompromised. And that's one of the conditions that would get you to the head of the line for vaccination under the age of 50 with 2 or more comorbid conditions. From the perspective of, there was other questions about, is the vaccine safe for certain conditions? There has been no evidence at all that it is in any way related to infertility or anything like that. Although there's no evidence around pregnant women, there's definitely no evidence around infertility. From the timing, it looks like everybody will be able to be vaccinated again by the end of the summer. But again, no contraindications. And for those who've had allergic reactions or anaphylactic reactions, the only recommendation is that you have a prolonged period of observation after the vaccine.
This question I'm going to direct to Dr. Barron. It relates to sort of risk factors for disease severity with COVID. A number of people have posed questions about vaccine eligibility tiered based on underlying conditions, but the most recent one in the chat is your thoughts on why obesity has emerged as such a risk factor for morbidity and mortality.
It's a great question. And, you know, we've seen morbidity and mortality with other viral diseases like flu, and specifically H1N1 in obesity seem to have a high correlation associated with that. Some of it may be, and I'm going to ask my colleagues to maybe comment on this further, as they may have some better insight. But certainly morbid obesity certainly goes with often other underlying medical conditions that, like diabetes, heart disease, things that that certainly can have some effect on immune responses, as well as the ability to respond in kind, where they have a hyper inflammatory reaction and then their heart gives out. And actually it was the heart attack that actually killed them, but it was related to the response of the disease. And so I suspect it's multifactorial, but I don't know if Dr. Campbell or Rochford have other thoughts or knowledge of specific to obesity, why they see so poorly.
Yeah, it's a good question, Michelle, but I don't know what it is about obesity other than it's linked to other conditions, as you've said.
And I
So,
would,
while you, and I'll get to you in a second here, Dr. Rochford. While you have the floor here, Dr. Campbell, can you address the question if somebody has had COVID, whether they should get vaccinated, and if so, the timing of that vaccination?
Yeah, that's an important question. So the first answer is yes, if you've had COVID, you should get vaccinated. And the reason for that is that the vaccine actually provides additional protection to you beyond what your immune system has already achieved from the natural infection. And that's additional protection against the current strain that's circulating in the US. But we know from the Novavax trial in South Africa that the new South African variant, the B.1.351 variant, that natural infection with the previous strain provides zero protection, no protection at all against the B.1.351 variant, whereas the vaccine is still roughly 50% effective. So with the spread of these variants in the US, it's important to get vaccinated even if you've had COVID. In terms of the timing of that, what the CDC recommends is 90 days after recovery from COVID. And the reason for that is that in those first 90 days, you have high levels of antibody, and those fall off over time. But for those first 90 days, you still have fairly good protection. And so it's okay to wait. Second thing I would add is that from the Moderna study, we know that people who had COVID previously have a greater risk of having injection reactions from the vaccine. And so if you wait a little bit and let that immune system wane, or immune response wane, it might reduce the risk of these kind of flu-like symptoms that occur after the injection.
Thanks very much. Now, Dr. Rochford, do you want to say a word about the biology and the inflammatory state associated with obesity and whether that interacts with the response to the COVID virus?
I think what I was going to just add on to the point there is that we think about when you get that viral infection, you get the replication of the virus, there's sort of two outcomes you can have. One is you can clear that viral infection, but you can also then, after the virus is cleared, generate this sort of sustained inflammatory response, this sort of a cytokine storm. And so we think that in the context of obesity and other situations, that might exacerbate that inflammation that's induced following that viral infection. So it's sort of an add-on effect. And I think there's a lot of studies going on our campus and elsewhere trying to understand that sort of immune response and why it's so exacerbated in some groups and not in other. But we think it is an exacerbated response due to sort of underlying conditions. So that's really important. And that's also when we think about those vaccines, even if they're 95, if they're reduced effectiveness, if they reduce the burden of the viral replication, you're likely to reduce that symptomatic disease because you don't have as much trigger to the body to generate that sort of secondary inflammatory response.
Okay, thank you. Looking at, there's a couple questions about previous allergies and allergic reactions and whether those require are a contraindication of the vaccine. I think you addressed this before, Rich, but do you want to say a word about what constitutes a contraindication of the vaccine? And if somebody's carrying an EpiPen because they have a severe allergy to shellfish or Hymenoptera or something like that, what implications does that have for their vaccine eligibility?
So the only, there are no contraindications to the COVID vaccine other than having active COVID infection. For those who have anaphylactic reactions, have any anaphylactic allergic reaction to anything, the only recommendation or change is that after you have been vaccinated, that you are observed for 30 minutes instead of the recommended 15 minutes. And if you look across the country, the number of anaphylactic reactions have been vanishingly small. So it is safe for everyone, unless you have active COVID infection and are under the age range. It is indicated and effective and safe for everyone.
Thanks. I'm going to direct this next question to Dr. Barron. And that is timing between vaccine doses. I think when it came out, the Pfizer was 3 weeks, but now some people are waiting 4 weeks. The Moderna was 4 weeks. What do we know about the interval between the 2 doses of these mRNA vaccines?
So the current recommendation for 3 weeks or 4 weeks was based on the clinical trial design. And so for Pfizer, that was 21 days plus minus 2 days on either side. For Moderna, it was considered the 28 days between those two. We don't have a lot of, we have some anecdotal information suggesting that if you go beyond those windows, that they're still effective, maybe perhaps more effective, but we don't know that. Right now, the recommendation is to try and stick to what the emergency use authorization has recommended. And so, and also, I will say from a logistics standpoint, to have people say, you know, I'm going to just wait, ends up throwing a lot of the operations piece behind this out of whack. We make you have both appointments scheduled just so that we know the vaccine is there, it's been thawed, it's ready, it's being given to you. And that allows us to be very efficient in those processes. When people start sort of saying, I'm just going to wait another day because I just feel like it, or till we have more data, I would suggest stay with the program, and not only again from just the consideration of that's the way it was designed and approved, and right now that's how we should be administering it, but also from the operations logistics piece, which I don't people fully appreciate how much work and effort it is to be able to make these run very smoothly, and having to change appointments frequently really causes a burden on the staff that are running these clinics, and then delays other people potentially from getting their vaccine in a timely fashion.
Thanks. So next question for Dr. Campbell here. So if somebody had side effects with their first dose of one of the 2-dose vaccines, are they likely to have side effects with the second dose? And then the converse, if somebody did not have side effects, does that mean they have a less robust immune response and are going to be less immune than somebody who did have side effects?
So in answer to the first question, yes, you will probably have side effects after the second dose if you had side effects with the first dose. But from what we know, those side effects won't be any worse than the first dose. And what I usually advise people to do in that situation is to pre-medicate themselves with some Tylenol after getting vaccinated, soon after getting vaccinated, to try to avert those symptoms. In terms of whether or not having side effects correlates with an immune response, we don't know. I've not seen data on that yet. But the real question is not whether it correlates with an immune response, but whether it correlates with protection. And so, you know, we can measure various immune responses, but those may or may not correlate with protection. So that's, I think that's an interesting question, but I've not seen those data.
Well, I think a lot of people comfort themselves when they're feeling lousy that this means the vaccine must be working. So,
It's doing something.
Yeah.
Doing something. It's your immune system fighting.
Yep. So Dr. Zane, question for you. A couple questions in the chat and the Q&A about strategies for getting vaccines out to vulnerable and underserved populations who, as we all know, have been disproportionately impacted in terms of mortality during this pandemic. Can you speak, obviously you can't speak to the national strategy about this, but can you speak to the local strategy about this?
Yes, so we have 3 specific workflows for vaccinating people. And then we have 2 very different workflows for registering people. So first, our backbone of our vaccination program are fixed clinics. So 11 clinics in the Front Range, open 5 days a week, and we can do up to 50,000 vaccinations a day. We've run 1, and hopefully we'll run more mass vaccination clinics, the one we did at Coors Field. And then we run pop-up or outreach clinics in local communities. And for those clinics, we typically do between 500 and 1,000. We've been doing 2 to 3 a week, partnering with community leaders. And the community leaders do the outreach to the members of their community. They collect the names, they register them, and they often accompany and volunteer at the vaccination sites. And that has really done a lot to get the local communities to, one, have less vaccine hesitancy, and the other, to feel as though they belong to a community that is being paid attention to and being vaccinated. So it's really important that we have those 3 different work streams. From a registration perspective, you can register either directly on the website, or if you don't have access to the website or don't have expertise in doing that, you can call a hotline and you can leave your phone number, and then you will be robocalled up to 10 times in the language of your choice. And then we will manually register you and manually invite you. So you don't have to have internet access or expertise with technology in order to be registered.
Thanks. So this next one, I think I'm going to direct to Dr. Barron because she's an infection control officer. So one of the questions in the Q&A was, with all this isolation and mask wearing, is it going to affect immunity to other diseases such as influenza, noroviruses, et cetera? And maybe you could say a word about kids and the typical respiratory season that we're supposed to be seeing at this time of the year?
So I'm not sure that I can really comment on the immunity part. I can definitely comment on the impact of the masking and the isolation and all the things that we've been doing, and that this has been the mildest flu season that we've seen in history, at least since I've been running the program for over 20 years. If you look across the spectrum, we've had maybe 9 hospitalizations for flu. Usually by this time of year, it's in the hundreds. And so clearly an impact in terms of lessening the spread of this. There's also been reports specifically about norovirus, which causes nausea, vomiting, diarrhea, really an unpleasant disease that spreads very rapidly because it's very infectious. And usually, again, this time of year is when we see this. Last year, there were reports of school closures due to norovirus infections where they had to shut it down and clean everything. And that, again, the reports of those have gone down to minimal numbers nationwide. And again, across our hospital spectrum, I can tell you we haven't had any in the last 6 months, which is very uncommon. So I don't know that this is going to necessarily affect our immunity, and that a lot of these we've been exposed to in the past. So I don't think we need to be constantly exposed to continue to have immunity. But I can tell you that the masking, the cleaning, everything we've been doing has had a significant impact on that. And it's hopeful that this will continue moving forward. And this may be a role for masking in this respiratory season as a preventative measure to prevent kids from bringing colds home, to prevent flu from being spread amongst our most vulnerable hosts. So I think there's a lot of secondary and third order effects that we're still evaluating, but this was one of the positives of all the things we've been doing. And I really believe strongly it's directly related to our mask usage, and then probably enhanced cleaning and hand hygiene as well.
Okay. I'll give this one to Dr. Campbell. You mentioned for people with side effects using acetaminophen or Tylenol to control those symptoms. There's some questions in the Q&A about the use of non-steroidal anti-inflammatory drugs like ibuprofen, Advil, Aleve, et cetera. Do they impair the immune response to the vaccine? Should people avoid those and stick with acetaminophen, or is it okay?
So there is laboratory-based evidence that taking a non-steroidal does affect different aspects of the immune system. I'm not aware of any data that would say that doing that actually impairs the efficacy of the vaccine. And so I've told people that if they want to take ibuprofen for symptoms related to vaccine injection reactions, that is totally fine.
Okay, thanks. Thanks very much. I'm going to give this one to Dr. Rochford. Recurrent theme in the chat and the Q&A, and part of the reason we're having this session today is around this issue of vaccine hesitancy, and specifically this belief among certain people that the mRNA vaccines in particular predispose people to autoimmune disorders. Can you comment on that?
So if we think about sort of this idea of what vaccines can and can't do, and especially the mRNA vaccine, like I say, when you get that messenger RNA, it gets inside the cell, stays in the cytoplasm, generates that, just the receptor binding domain, just a very small part of the virus, and you make antibodies to it. And then that mRNA is degraded. So there's not really any evidence of autoimmunity as a consequence. It's way too early to know that, but there's no evidence of autoimmunity with other vaccines as well. So from a sense of, we make, let me think about it a different way. Our body fights off all kinds of things all the time, and we make antibodies, and the risk factor for autoimmunity has nothing to do with sort of the vaccines. It has to do with sort of risk alleles and your genetic susceptibility. So an mRNA vaccine is going to be, the messenger RNA is there in the cytoplasm. It's going to get degraded and gone fairly rapidly after it makes that initial just part of the virus. So there's not any data to date to suggest that we're going to get autoimmunity to this vaccine or to this virus. So I would just encourage people not to think about, it's just our immune system is great and we're just helping it make a good vaccine and immunity to this virus that could kill us. So think about the more immediate threat.
Okay, so I think we're at the end of the hour here. I'm just going to say one or two things based on what I see on the chat. One was about the timing of other preventive healthcare measures like a mammogram or cancer screening. I think if you've been vaccinated and you're 2 weeks out from your vaccine and immune, you should get the kind of healthcare, including preventive measures, that you need. There was another question about the utility of treating COVID-19 with hydroxychloroquine. We have data on that, and the answer is no. And the last thing I would mention, a few people have asked whether this session is being recorded or not, and at least according to my screen, it is. So I'm sure the people from Advancement will send out an email with a link so people can access the recording should they want. And with that, I want to thank our panelists, and I'm going to turn the floor back over to the Chancellor here.
Thank you, John. And I too want to thank our panelists for making the time to share this information, which was, I think, pretty invigorating, given the number of questions that we had in the chat and in Q&A. Obviously, people are still pretty engaged with this. As you can imagine, we had many more questions submitted than we could get to today. We encourage you to visit the CU Anschutz newsroom at news.cuanschutz.edu for the latest information on our campus response, including a new vaccine story series. We will circulate a link to the newsroom along with a recording of today's panel as a follow-up. So in closing, be well, be safe. When you get invited, please be vaccinated. We all believe in it. We thank you for all you're doing to help keep our Anschutz community strong. We will get through this together. Thank you very much.